right. Thank you for joining us for this webinar, Research to Reality, What Prostate Cancer Updates Mean for Your Journey. My name is Jeremy Patch, Senior Director of Patient Programs and Education here at Zero Prostate Cancer, and I'll be serving as your host. I'm excited for you to hear from our speaker shortly, but first I'd like to share a few notes before we get started. Today's webinar is being recorded and will be posted on our website later this week. Closed captioning is available at the bottom of the Zoom window. Look for the two CCs in a box and select Show Captions. As soon as the event ends, you'll see a link to a survey. We want to hear your feedback on this event, and we'd like to hear from you. So please take that survey when you see the option at the end of our webinar. Please drop your questions in the Q&A feature, and we'll answer as many as possible after the discussion. Please keep your questions general. Neither Zero nor our speakers can provide medical advice or address individual patient histories. And as you see here, while Zero Prostate Cancer has curated this event to share evidence-based information and best practices, the views, opinions, and statements expressed by guest speakers or remarks made during or outside of formal presentations are their own and do not necessarily reflect Zero's official opinion. Zero does not take responsibility for individual speaker remarks. This event is for informational purposes and does not constitute medical advice. Please consult your own healthcare provider for guidance specific to your care. Now we've also got a poll question here if we're gonna be a little interactive. So you'll see a poll come up shortly. We appreciate your participation. How knowledgeable do you feel about new treatment options and research findings currently? So we'll give you a few more seconds to participate. Thank you all. Got a lot of people joining today. That's exciting. Okay. Thank you for your participation. We appreciate that. And we'll have another poll at the end. First, I want to thank also our sponsors, Novartis and Bayer, for sponsoring today's webinar. Their support makes educational opportunities like this possible. And Zero Prostate Cancer is on a mission to improve and save lives from prostate cancer through advocacy, education, awareness, and support. Our vision is a future where prostate cancer detection is early, support is unwavering, and care is accessible to all. If you're new to us, this will tell you a little bit about us. Thank you. Next, I'm excited to talk about our relatively new program that we launched earlier this year, ZAC. It is a 24/7 virtual support tool. You can use the QR code there. You can start a text conversation immediately if you use that QR code, or you can just text 1-844 and the number there. I'm having trouble reading it on my small screen, sorry. Zach can link you with Zero support programs. It can answer your questions about diagnosis, treatment side effects, test results that you may be, questions for your doctor, can help you prepare for medical appointments. So we encourage you to utilize this great service. It can connect you to peer support, give you more information on clinical trials, just a host of questions. And if you just really kind of need someone to chat with to get you started in this conversation, text Zach and it can help provide virtual support 24/7. We've also got many other programs, which I'll review very briefly. You can also always just text Zach for information about any of these programs. Just say, tell me about Zero's programs, and it can give you information. So 0360 is our patient helpline. Patients or families can call and be connected to a case manager. Call 1-844-0360. They particularly are great at helping connect patients to financial resources if you're having trouble paying for bills, whether it be medical prescription drugs, or even everyday cost of living. They can help with connect you to resources. They can walk you through insurance options, great options. We have patient navigation that pilot programs that we've launched in Atlanta and Baltimore. So we encourage you to text Zach. It can connect you to one of our navigators if you're in the Atlanta or Baltimore area. We've got peer support programs, mentor one-to-one programs, support groups across the country, also offered virtually. We've got online communities where you can ask questions of other prostate cancer patients, caregivers, survivors, education resources such as today's webinar. And we've got the special veterans program. We've got some new veterans online communities that we've just begun. So you can text Zach and ask for information, identify yourself as a veteran, ask for information and support as a veteran. Before we continue, I want to remind again everyone that this webinar is being recorded and will be available later on our website, zerocancer.org. We want to plug our upcoming fall Run Walk series. It's a great opportunity to get engaged with Zero, to support our programming and our mission, and really meet people in your area. Go to our Run Walk website to find more. Again, you can even text Zach and ask for information about our Run Walk series and if there's one one in your area. So we encourage you, or use the QR code too. We're going to leave this up for a second if you'd like to pull up the QR code. But we look forward to seeing you. We hope we will see you at one of our Run Walk events in the fall. Now, please join me in welcoming our esteemed speaker, Dr. Yaw Nyame. Dr. Nyame is a urologist who specializes in cancer care at the University of Washington Medical Center and Fred Hutch Cancer Center in Seattle. That's the very brief synopsis. He told us to keep it brief, but you can read there more. We're excited to turn it over to Dr. Nyame now and learn more about what's new in prostate cancer. He'll be pulling up his slides, so give us just a second for some transition. Dr. Nyame, we look forward to hearing from you.
Jeremy and Nicole, thank you so much again for the invitation. As you guys know, these opportunities to share and engage with patients in all phases of their journey is really important to me, and it's probably one of the more enjoyable things I do, even if it creates a little bit of stress because it forces me to be an expert in some arenas that I don't normally manage personally, right? But it is really exciting, I think, to take a minute and be able to talk about what meaningful updates have occurred in our field. You know, as a urologic oncologist, my specialty is surgery, and surgery is what I'm most expert in. But, one of the things that we are required to be able to do as prostate cancer doctors is understand a little bit about all the different types of treatments that are available for our patients. And so I think some of our biggest updates from meetings like ASCO are going to focus on medical oncology. And I just use this moment to give the disclaimer that although I have familiarity with these treatments and understand what their benefits are, when it comes to the day-to-day management of these drugs, for instance, that's not a big part of what I do in my clinical practice. These are my disclosures. They're mostly research funding disclosures. Many of them are coming to an end. I also serve as an advisor in an advisory board capacity for Johnson & Johnson in the past 3 years. I really want to promote open dialogue. I know this format is really set around having questions being sent through the Q&A. Please do so. I think I have about 25 minutes worth of content, so there should be time for me to be able to answer any questions that you may have about the research studies that we share. As a researcher at the University of Washington, one of the things that I really have built my research program around is doing research in partnership with patients and survivors. And we've done this through a group called Backpack. And I think one of the beautiful things about Backpack has been that it's been a coalition and partnership that includes members of Zero, organizations like the American Cancer Society, FEN, and I think it's really important that and what I've learned through that is how to communicate about research to survivors who often have great ideas about where we should go next. But also, I've learned that it takes time and sometimes multiple opportunities to digest, the full scale of these studies. As I go through them, I really want to focus on a couple of things. We're not going to get too heavy into the design or, do we think the results are credible or how's this going to be implemented into my treatment today? I just want to highlight these important studies, maybe take a couple of minutes to answer the first question that we as scientists always want to know, which is kind of the like why and how, why is this important? How is this going to impact our patients? And then to go through a little bit of the design at a really high level, and then focus on those key results that have made all of us, either as researchers or clinicians, excited. And we have two really big meetings in the field of oncology affecting the genitourinary system, which is where prostate cancer falls. One is called the ASCO GU meeting, typically held in San Francisco in February, and the other is ASCO, which is a larger clinical oncology meeting that's held in Chicago at the beginning of the summer. So most of the information I'm sharing today are going to be sort of these big highlight. We use this term plenary, which means, it's kind of the main stage presentation, sharing kind of the biggest results of the year. And I wanted to select a handful of projects that fell into that category that I think are going to either change the way we practice or starting to tip us into practicing in a different manner. I started by saying I am a urologic oncologist. I'm a prostate cancer surgeon. And so as a result, I'm going to start with prostate cancer that is localized to the prostate, an arena of which I, have a lot of familiarity with. And I'm going to start with our newest study that's named after the Greek god of the sea, Proteus. And I use this slide here showing a kickoff return because I think about what a kickoff return really is. It's this really Herculean task. And I think we have some subsets of localized prostate cancer where the odds of taking the football from one end of the field to the other, going up against the cancer, which in this example is the Washington Commanders, and they were chosen randomly here. I just want to be clear there. And and I think, if you pictured here, no blockers, no lead blockers for Devin Hester here, it'd be pretty hard for him to get down the field. And so I think for many, many years, and in many other cancers, we have this ability to say, let's send some lead blockers before we try to run the ball down the field. And in this analogy, running the ball down the field is surgery. And those lead blockers are going to be medicine that treats the whole body. I always say that, when we talk about this term neoadjuvant before surgery treatment, we are trying to treat cancer throughout the entire body. And can we use that strategy to increase the success that we score a touchdown with your cancer operation? And if you think about who would benefit most from this more aggressive strategy, it's going to be our high-risk prostate cancers. And we define high risk in a variety of ways. In this study, they use a really classic definition. These are our grade group 4 and 5 cancers, also known as Gleason score 8 through 10, or patients with PSAs greater than 20. We can also have a clinical definition where there's clinical suspicion that you have what we call T3 or T4 prostate cancer. So those were the people who were eligible for the study, and the study enrolled over 2,000 patients that met this criteria. As some of you may know, the way that we can really tell if something works and is effective is to, before we do the study and collect data, really clearly define what we're going to measure. In this study, the measurement was, do you develop stage 4 prostate cancer after treatment? Stage 4 prostate cancer is closely linked to prostate cancer death. And so it is an important thing for us to try and prevent. And so it is a great endpoint for us to measure in our patients. The other endpoint they wanted to measure, which actually is not one that we typically use as in prostate cancer, but we use in other cancers like bladder cancer, is this idea of a complete response. So when we go to surgery, is there no evidence of cancer left in the prostate? So those were their two primary endpoints. As you know, a computer essentially randomizes or does a coin flip for patients to the drug that we think is going to help compared to a placebo. And in this study, the drug that we compared in this Proteus trial was apalutamide, which is a androgen receptor pathway inhibitor. It is a newer um, and a form of enzalutamide blocking the androgen receptor. Has a very similar mechanism, slightly but tolerated better, and has been shown in a number of metastatic trials. So patients who have stage 4 cancer to improve survival. So there's data that show to suggest that there's a mechanism in which this can be a more effective treatment for prostate cancer from our metastatic setting. And the question now is, can we move it even earlier in this high risk population? Now, I didn't share this yet, but the important thing that I really want to say here is that we have done this study many times before as a field. In fact, the lead author of the study has done multiple studies in this space where we've tried to see if different medications could reduce the risk of a man either having their cancer come back or develop as a biochemical recurrence or spread. To to a new site after treatment, and all of those previous studies have been negative. One thing that I think is really interesting in this design is that it really is treatment around the time of surgery. So we have 6 months of treatment before surgery, followed by 6 months of treatment after surgery. And so, this was a slightly different design than prior studies, and you'll hear this termed as sandwich therapy, and it's a combination that's been used in other cancers, where we're thinking about sending those lead blockers to help our primary treatment have the best chance of being effective. So having spent all this time just describing how the study was done and conducted, why was this such a landmark study for us? Well, I told you all of the preceding studies had been negative and had not shown a benefit to doing treatment around the time of surgery. And lo and behold, our two primary endpoints that we had for this study both showed that getting this drug, apalutamide, with ADT was more effective than ADT alone in a randomized control study. And a couple of things to really point out right away. Almost 10% of the patients who got apalutamide and ADT around the time of their surgery had no cancer or really, really tiny amount of cancer, which the authors defined before this trial left over in the specimens that were taking out in surgery. This was a 9 times higher risk of, or a 9 times higher likelihood of having no cancer left at the time of surgery. And we know from other cancers that having no cancer present when we look under the microscope in someone who's had treatment around the time of their operation often leads to higher odds that you're going to be cancer-free in the long term. The study also showed a 20% reduction in developing metastatic prostate cancer or dying from prostate cancer after surgery if you had this combination treatment. And that was a significant improvement with the addition of apalutamide. And the way that we always tell on these curves is we want to see if the two curves, we say split. Do they start to separate apart from one another? The study had about 5 years of follow-up on average for everyone who participated. And you can see somewhere around 2 to 3 years, the two groups start to separate from one another. So we called this a positive trial. It showed a benefit to this combination of treatment in high risk prostate cancer patients. And I think there are some interesting things that in this trial. The PSMA PET scan was FDA approved during the time of the study. It was allowed as a way to measure metastatic cancer. So in a way that makes it contemporary or relevant to us in the present time. And so the question becomes, is this a new standard of care? And I think the answer is yes. I mean, it was done rigorously. It shows a benefit to treatment. And I think many of us, we participated in this study as a site, and I think many of us are looking at this data and I think are going to be hard pressed to not think of using this combination of treatment for our high risk patients that are interested and think that the side effects of apalutamide are acceptable. But I want to point out something that's really important to notice from the study. Most of the time when we are doing randomized control trials, we compare standard of care plus a treatment that we think is going to work to standard of care by itself. And surgery plus hormone therapy sandwiched around the time of surgery is not the standard of care for high risk prostate cancer. Um, and I think, future study is in the planning with this positive result to do what I think would be an even better comparison of standard of care versus standard of care plus what we think will be beneficial, which would be surgery alone versus apalutamide plus ADT with surgery. And so I think that study is in the planning, and getting that data would be the slam dunk that this will be the way moving forward for how we manage high-risk localized prostate cancer patients. So the next exciting study is in the localized prostate cancer space as well. I put this up because I think sometimes when we talk about radiation, it's something that we can't see or smell or touch for the most part, and so it feels not tangible. That's what I think about radiation, but it's around us everywhere, right? It is energy passed through air in the form of a waveform, and we know that we have radiation that is non-ionizing and ionizing. It's all around us in our power lines and the radio and TV broadcast signals all the way through the medical applications of radiation that we use. And I think this chart does a really good job of highlighting all the forms of radiation that we see around us. Um, there's been, for me at least in Seattle, at the UW Fred Hutch, we have access to proton therapy, and we've had it for a really long time. And so this is a conversation that I have with patients pretty frequently. And most of the data that we have has shown that proton and photon energy may be fairly similar, but it's usually retrospective data, and we haven't had kind of the large forward-looking comparison that we typically rely on to say that things are equivalent or one treatment is better than the other. Conventional radiation is done with photon, and even though we can really decrease the dose of radiation around non-targeted tissues, that dose gets redistributed around to the non-targeted tissues, excuse me, whereas proton therapy can really reduce the dose that non-targeted tissues see. And we think from the physics calculations that it can do this by as much as 50%. And so you can see here two different maps of treatment maps that show maybe how that redistribution with the photon therapy on the left compares to the proton therapy reduction in dose by 50%. Now, I love this study. I'm biased, but it was supported by a funding organization called PCORI. And the reason I say I love this study and I love is because PCORI's approach, which really aligns with the way we think about research, is all about answering questions that are really important to patients and doing trials that are really patient-centered. And so this is a lovely example of that. This is a pragmatic, non-randomized control study. And so patients are not randomly selected to have either proton or photon therapy. And that is why thousands of patients are required, because even though we are collecting all of this data rigorously upfront in a study like this, we need to be able to control for all the variables that may differ between these two groups so that we can make them as similar as possible when we measure the outcome that we're interested in. And the outcome that was measured in this study, which I think is really important to highlight, are patient-reported outcomes. So how are patients doing in the study? And the second outcome that is measured, which I think is also important to highlight, is are the treatments equally effective? And so this study accrued patients between 2018 and 2022, and at this year's meeting, ASCO meeting, it provided an early results that were pre-planned to be evaluated to us. Now, one thing to also note about pragmatic trials is that they really are happening in the real world setting. And so if something new happens in practice, they can be captured in that type of trial. And so rectal spacers were placed in this study, and they were able to evaluate the impact of having a rectal spacer at the time of your radiation treatment on your symptoms and outcomes. They excluded very high risk and metastatic patients. And again, I think that these two treatments, the comparison of these two treatments is important because of how much it matters to you as patients. The first thing to point out is that they had hypothesized actually that those getting proton therapy would have about 8% lower risk, or in this case, a twofold lower risk of bowel symptoms and bowel-related toxicity. You can see what they hypothesized in this middle column, and they thought that overall the cancer recurrence rates at 3 years would be fairly similar at around 90% between the two groups. Now they show on the right side here what they actually measured at this 3-year outcome with regards to both freedom from cancer progression, but more importantly for the bowel symptoms, which was that the rates of bowel toxicity or having diarrhea, bowel urgency, frequency was very similar between the two groups, and in fact was not statistically significant, the difference. And they were able to adjust using this math, statistics method called inverse proportionality weighting. They were able to use that method to make these two treatment groups really similar, and they had enough patients that was a statistically rigorous way to do this upfront comparison. The other thing that they were able to do, because they, again, world setting, was look at the rates of toxicity for those who had spacers placed, like the spacer device, a rectal spacer, versus those who didn't. And again, it was very clear that a spacer reduced bowel toxicity, meaning diarrhea and the urgency that you can have with radiation to go to the bathroom, decreased at about half for both treatments. And that difference between the spacer and no spacer groups was statistically significant. So for me, this is kind of like the Spider-Man meme. You got for the protons and the photons staring each other down, saying, "Hey, we're pretty similar, aren't we?" But I think that's really important to patients as they make decisions about their treatments, to know that they're not compromising, quality of life or cancer control if they don't necessarily have access to one treatment versus the other. And so it deepens the amount of options that we have for our patients, which I think is always a good thing. So that kind of concludes the two major highlights that I wanted to point out in the localized prostate cancer setting. I'm going to quickly talk about things in the metastatic prostate cancer space, which I think also had some very exciting updates. Because of the continued advancements of therapeutics, which are often used in the metastatic setting. I have to admit that we tend to have more big annual updates in the metastatic setting, which is great. I think is really good for patients. And I selected three studies that I think highlight three really different outcomes, but important things to patients as we continue to improve the way that we deliver care. I used this slide last year, which was borrowed from Dr. Misha Beltran, which I found this online. I'd seen her use it. It's such a beautiful slide showing all of the innovation that's happening in the field of prostate cancer as we have many, many, many new targeted drugs and agents to treat metastatic prostate cancer, and our ability to start shifting many of these treatments from the hormone resistant part of the disease journey earlier and earlier into the hormone sensitive part of the journey. And I'm going to start with our PARP inhibitors, which are inhibit a natural way in which our body repairs DNA. And so what I can say about this is that if a cell in our body has damaged DNA and we know that it's going to produce bad copies of future cells in our body, we tend to allow that cell to undergo what's called a process called cell death so that we don't continue to make copies of that bad DNA. Cancer cells often are making copies of themselves so quickly that they have an error. They have a hard time dealing with any errors in the code for their cells, and that's what our DNA really holds the code for. The tissue, the cells that are part of the tissues that make us who we are. PARP inhibitors can prevent cells from fixing DNA errors. So we have all these processes in our body that are spell checking the DNA, and sometimes if they notice that there's a particular error, our bodies can fix it with this mechanism called PARP. And if we have a drug that, like a PARP inhibitor, it can turn off that mechanism that the cell is using to repair these DNA errors. And this is especially important in cancer where we're trying to not allow cancer cells to live. So, last year I presented Talipro 2, and one of the things I said was, well, if you look at the data, it seems like this drug would be more effective in cancers and cancer cells that already have a damaged ability to repair DNA. And we have a term for this, the DNA damage repair genes, or homologous recombination repair genes, which is a specific subtype within this space. And in other cancers, we've known that these drugs that block DNA repair are more effective when the cancer cells themselves also can't fix DNA damage on their own. And the question that I think was answered in this year's updated presentation of the Talipro series of studies, Talipro 3, was, can we start this even earlier? So instead of in the hormone resistant setting, can we do this in the hormone sensitive setting? And again, I show you the trial design. I'm not going to quiz anyone on their understanding of the entry criteria for this, but it's important to just know that part of why these studies are so important is that, clinicians, researchers, and oftentimes now we're doing this with patients, sit down and go through all the variations of who we need to include in the study, who we need to exclude because it might contaminate or make our results difficult to interpret, and what are we going to measure? And the key endpoint was progression-free survival for the study, and it compared talazoparib to a placebo in patients already receiving enzalutamide. And the entry criteria for the study, which I think this is really important, was that the cancer had to be tested and proven that within the tumor there was one of these DNA damage repair alterations present, either in the tumor or in your own biology that you were born with. And so if you look at the study results, again, getting straight to the point here, I want to demonstrate that there was a significant advantage from not having new progression of your cancer when in this very specific subset of patients when this talazoparib it was added to enzalutamide versus enzalutamide alone. You know, we have talked for a long time about personalizing oncology, and this is one of those beautiful examples that if we test your tumor and we sequence it and understand that you have one of these um, DNA repair mutations present in your cancer, we now have a very specific combination of medication to give you that delays progression and ultimately, yeah, which we will see in future studies, hopefully delays um, progression that leads to cancer death. And so this is a really a major development in our field. Second thing I wanted to talk about, which is moving into a complete different area, is this idea of brain fog. And I think many patients who've had to have a systemic cancer therapy might experience this. It's that ability to like losing the ability to focus, think, maybe navigate a space that you knew very well, like a parking lot that you're familiar with, suddenly feels really foreign. And some of our androgen receptor pathway inhibitors have been known to create quite a bit of this, and patients have reported that, and this has been documented. This is a study led by Alicia Morgans, who's at the Dana-Farber, and I love the design. Again, I put it up as a reference, but you know, it's patients were allowed to enter the study in this open label trial, and they were randomized to one of two drugs for metastatic cancer. It was a total of 111 patients. And what I really love is that after a period of 3 weeks, if they met certain patient-centered criteria, they were allowed to cross over or stop taking the treatment that they were on and take the other drug. And most of this was driven around symptoms. At the bottom, I show the tools that were used for assessment. This is the type of research that our team does here at University of Washington through our center cord. And so we are very, I very much love to see these patient-reported outcome measures being collected where patients are telling us how treatments affect their quality of life. And I mentioned the unique crossover design. If you look here, enzalutamide was associated with a higher risk of having a change in cognitive domain that was negative. So you can think of this as a higher likelihood of symptoms like brain fog, and it was about a 2 times higher risk of that among the 50 or so patients that received enzalutamide compared to darolutamide. Um, and if you look here, the two drugs could affect cognition in different ways as well. So you see enzalutamide having a bigger change in working memory, so losing your train of thought in while telling a story, and executive function, you know, so the ability to plan the steps to complete a task when compared to darolutamide. And I think it's important to also note that only patients on the enzalutamide arm chose to cross over to the other option, which was darolutamide during the study. Last but not least, new kid on the block. I love using the slide. The 80s were a heck of a time. You can tell from this picture. We have a new FDA drug, approved drug on the market. This is really exciting for prostate cancer patients. You know, I will take very briefly just talk about this. You know, there's this publication that came out this year in the Annals of Oncology. This one's unique. If you look here, it starts with the number of patients screened. That means that they had to look at each patient's tumor to see if they had this particular genetic alteration to be eligible for this drug to be effective. And so once they were screened, if they were eligible, then they had the option to randomize. And they randomized 1,000 patients to this new drug, capivasertib. You can see even myself, these drug names are always hard to pronounce. And they compared that combination of capivasertib and abiraterone to placebo and abiraterone. and that showed a survival advantage for patients who have a particular anomaly called a P10 deficient cancer, which was in their study about 25% of the patients. The main side effects were GI, high blood sugar, rash, low blood counts, and low potassium. Um, but overall, it seems from reading the paper and from the literature that's come out around this drug that it's fairly well tolerated. It's attacking a very specific change in the biology, and it seems to provide a survival advantage over abiraterone alone, which is really exciting with regards to having a new therapeutic option for our patients. So, with that, that concludes my presentation. Uh, I always love to highlight the wonderful men and survivors and women who are partners and research team members that make the work we do possible. I really want to highlight our backpack group, many of whom also have strong ties to Zero, for their continued partnership and for all the exciting work that we get to do together. There are far too many of them to call out individually, but they know who they are. Hopefully, some of them are on the call today, but we're really grateful for all the things that you guys do to advance prostate cancer research. And with that, I'm happy to take any questions you may have.
What a great presentation. We appreciate that. There have been a lot of exciting things happening in the prostate cancer space, and I know ASCO, because it's a huge conference covering all cancers. Sometimes prostate cancer isn't a big feature there, but there were a lot of exciting things coming out of it this year, so it's great. Thank you for the rundown, and it's always exciting when we get a new FDA approved drug option as well to give patients more options for their care. So appreciate you covering all of that. We do, as you know, we've got you've done these enough. You know there are lots of questions. So I'm gonna
Lots of
go through some of these for you. One is a question. They say they're a caregiver to an African American prostate cancer patient, and they had intermediate unfavorable prostate cancer, but really their question centers around genetic testing. They're concerned about, the potential that they've passed, genes, genetic mutations on to their children. Can you talk more about like genetic testing and the conversations you have with patients and who may be eligible for genetic testing, or even talking to a genetic counselor perhaps could be a good first step. Can you talk more
Yeah,
about that?
sure. So prostate cancer has for a long time been felt to be the most uh, inheritable cancer of the solid cancers, and that goes back to some studies that were done in Sweden that suggested that maybe as much as 65 or 70% of your risk of developing prostate cancer um, was due to your family genetics. I personally think that number might be a little bit lower, maybe closer to 50%, but still significant. In my clinics, I always ask men, do they have a strong family history of prostate cancer? Because if there's a first degree male relative that had prostate cancer, especially prostate cancer that was metastatic or fatal, there's an increased risk that you may harbor some genetic predisposition to prostate cancer that we can actually detect or measure. Um, there's also other ways that we can measure genetic risks that don't always have to be kind of what we call rare variants or uncommon genetic mutations that you inherit that increase your prostate cancer risk, that just generally move your risk up a little bit. And for most men, I think, irrespective of race, yeah, I'm asking those questions about prostate cancer in the family. I'm also asking about any other cancers, breast, ovarian, colon, pancreatic cancer, because there are strong links between some of these genetically inherited risk factors for cancer and other cancers that people can have. So if you screen positive on those questions, yes, dad, uncle, brother, granddad, or yeah, my mom had breast cancer, my sister has breast cancer. I'm very fortunate I can put in a referral for a genetic counseling appointment, which is probably the best way to get genetic testing, because then you get a full discussion on the risks and benefits of testing. You can get the testing done, and then when the results come in, if they're positive, our genetic counselors are so helpful in doing a lot of the next steps. How do we talk to family about a positive genetic test? What do we do with this results? When should my children undergo cancer screenings based off of this result? What type of cancer screening should they have? So some they may need a mammogram, some they may need a colonoscopy earlier if they test positive themselves. So the genetic counselors can be really helpful for that. For prostate cancer, those rare variant mutations that we may pick up are things like BRCA. So I know BRCA is named BRCA because of breast cancer, but the risk is among patients who have BRCA, one mutation is about double maybe, and the risk among those with BRCA two mutations can be as much as 5 to 9 times higher risk of developing prostate cancer. ATM, HOXP13 are also really common mutations. Again, I'm not expecting anyone to memorize that, but these are things that you may want to be aware of. For men of African ancestries, there have been some rare variants that seem to be linked to that West African genetic ancestry, especially on the HOXP13 locus. But we don't have, I would say, the extensive kind of data to suggest that all men of African ancestry necessarily need to undergo genetic testing. So I treat it very similar. Is it strong in the family? And if it is, then I'll make the referral like I do for other patients. That was a very long answer, but I hope that kind of gives the global context around genetic screening for prostate
Yeah,
cancer patients.
I appreciate that, and thank you for widening it to the whole kind of family conversation. It's not just about what cancer your dad might have had and prostate cancer. It's breast and ovarian and pancreatic, like you said. So thank you.
Yeah,
Um,
and
real,
colon, don't forget, there's a
yes, yeah,
strong link there too.
yeah. And related to that, there was a question in here. You mentioned AMT mutation, so there was a question about that. When you have the AMT genetic mutation, are PARP inhibitors effective?
Yeah, so the ATM mutations
ATM, sorry.
definitely, yeah, that's okay. They are a DNA damage repair gene. They're part of that pathway, and so yes, we think at least based off of talopro 3, for someone who has stage 4 prostate cancer, a PARP inhibitor has the potential to be not has the potential, has been shown to be effective. I shouldn't hedge so much. Has been shown to be effective in reducing progression and death in patients who has that. So. I think you're gonna, if it hasn't already been something offered, it's something that to patients with those mutations, you're gonna see that being done much more with this evidence that's been generated.
Okay, great. There were a lot of questions that came in around the time you were presenting on when you were talking about localized stage and apalutamide and around the time of
Sure.
surgery, the use of that study. One question was around surgery itself, and what do you mean by surgery? And I
Yeah,
think that, that's just a very
that's
great starter
that
question, right?
that's basic. Yeah, surgery meaning removal of the whole prostate, the entire prostate, and sampling lymph nodes in the pelvis.
Yeah.
um, which is a standard procedure we would do for a high risk patient undergoing surgery. And that could be done robotically or open in this trial, I suppose, but I would guess that almost all of the surgeries were done robotically because that's just the way that they're primarily done today.
Okay. Thank you. And one of the questions was, and I think it's just good to revisit that, was this used while the prostate cancer was localized within the prostate?
Yeah,
Confirm.
so for 6 months, the patients were on treatment with their prostate still in. Then the surgery was performed. They had a little break from the treatment while they were healing up. And then about a month after surgery was done, they went back on and completed another 6 months of treatment with the prostate out. And that's what, I use that term sandwich therapy around surgery. That's what the sandwich is. So if the surgery is the meat, the two treatments on either side of that are the bread. So there are some. there's some criticisms of that type of design. I don't think it's one of those things that the clinicians and researchers should argue about, but I think it's a concept that we're seeing more and more in trials that are looking at the benefit of treating your whole body with some drug um, in addition to surgery versus surgery by itself.
Okay. Thank you for that. Um, Here's a question that I think is an important one. When should patients stop active surveillance and look into other modalities?
Yeah, great question. I think historically best the best indicator that it's time to come off treatment, I think for me, has been uh, what I call reclassification or progression. Some will use that term by cancer grade on biopsy. Um, I mean, I think that has always been the easiest indicator to say it's time to treat. So you had Gleason 6 or grade cancer or grade group 1 cancer on one biopsy. Now you have grade group 2 or 3 on a biopsy. I think that that's always a time where you should stop and say, is this a sign that either worse cancer has developed or things are getting worse and I need to, or we've detected a more aggressive cancer that was always there and it's time to undergo treatment. Um, I think PSA, for instance, is a very soft indicator, and I tend to not let that drive treatment. However, it may lead me to recommend a biopsy sooner. So if I had told one of my patients, hey, we'll get a biopsy in 3 years, and then their PSA starts to rise in a concerning way, I might say, let's get that biopsy sooner because I really, really want the pathology progression or reclassification to dictate more treatment. The other one that, and I'm just going to say it here because I think it's important, and is patient preference. I mean, I think sometimes patients get fatigued. You're older, things have changed with your priorities, and you know, I think it's time to just treat and not keep undergoing repeated procedures and biopsies. And yeah, I think when I was early in my career, I would hear people describe that sometimes as a failure of the clinician not convincing the patient that to stay on surveillance because it was safe, etc. I think with some seasoning, I really see this as an important conversation that we need to have with patients to know that there's always the opportunity to treat, and if that's something that as aligns well with the patient goals and they understand what the risks and benefits of that, especially if there are some data points that have been changing, that's very reasonable, even though we know that most low risk cancers, if things are stable, are safe to continue to watch.
Appreciate that response. Thank you. Well, that's all the time we have for questions. Unfortunately, we know there are many more. We appreciate all the participation. Speaking of participation, we're gonna put a couple of poll questions up. One, quick one here. We'll give you a few seconds to respond to. Oh, there's a couple. They're both together. So notice 1 and 2. If everyone can please just go ahead and respond to both questions. And while you're doing that, I just want to say to you, Dr. Nyame, thank you again for joining us today, sharing such wonderful insights and updates from, the important things that have been research updates from conferences for the drug developments and drug approvals. It's great information for our community. As we close today's webinar, I want to remind everyone to please fill out our survey. Look for that in the chat. You'll also see it in an email tomorrow, which will also include the location where we'll place our recording of this if you want to go back and view it or share it with others. Thank you again, Dr. Nyame, to you for your time today. We look forward to seeing you, all of you, at our upcoming events. We've got a webinar at the end of August on biomarkers and what's happening in the biomarker space and the importance of biomarker testing. We kind of talked a lot about some of the mutations and things, so important. We can continue that conversation in August with Dr. Raina McKay. So we're excited to hear from her. thank you again to everyone. Thank you, Dr. Nyame, and we will see you hopefully in August. Take care,
Absolutely. Have a
everyone.
great day, everyone.
Thank you.